Hi. Sandra, are you a participant, an organizer?
Excuse me,
Are
can you
you
hear me?
are you a participant? Are you one of the organizers or?
Yeah, one of the interpreters.
Oh, interpreters. Okay, great. Good to
Or
meet you. My name is
okay,
Rhodora.
me too. And Rhodora, Sandra.
Okay.
Are you one
So
of the facilitators?
yes, there's three speakers on this session, and so I do have to be mindful when we have an interpreter, I have to not speak so fast, correct?
Yes. Just because sometimes for every 2 words you say, we have to say 3 or 4.
I
We
know.
use abbreviations, yeah.
Okay. We have a lot of content. So, okay, that would be a good tip to share with my two colleagues when they join. Because I've been to a conference in Santa Clara. Oh, where are you based, by the way?
I'm here in Tucson,
Oh,
Arizona.
in Tucson. Okay, we're in California. Yeah, I was at a conference where it was live interpretation. There was a
Mhm.
Vietnamese translator. And so, yeah, I remember the speakers had to be very good, mindful about not speaking so fast.
I have one question in terms of the way this is going to work, because I've never worked with Notch. Does do we have like a breakout room with the people, or is it simultaneous and you speak?
See, I don't know. So
We'll figure it out.
Andrew, this is
Hi there.
Sandra, and
Yeah.
Hi.
she's a
Sandra.
Spanish interpreter for
Okay, super.
today. But I don't know. I didn't receive any guidance on how the logistics works. Like, I'm not sure. Like, is it that we say something and then we give Sandra time after each slide to summarize, or
Is it
did you get any
simultaneous?
guidance on that,
I
Andrew?
did not. But it's great that you're here, Sandra.
I know.
Yes.
Making it accessible. You have a very important role.
Yeah, well, we can see if we can ask. I know there's people from Nashua here to support. This might be someone.
Hey, Rhodora.
How
Hey,
has it
Andrew. How
worked
you
in
guys
past
doing?
webinars that
Hi.
you've done? Oh,
So, I'm helping out with Natura, and I was
oh,
gonna say, there's not any like specific breakout room or anything. So I want to say that just allow a brief pause after you say your statement, and then Sandra will follow up after you.
Okay.
Okay.
And I'll just confirm it just to make sure.
cool.
Great. Well, yeah.
Well, that's good. We'll
Yeah,
get
Sandra.
Uh-huh.
We'll try to be mindful on our end to, take adequate pauses and make sure that you have
Thank
time.
you. Yeah, I've just been in other conferences where there's a breakout room for all the Spanish speakers, so it goes at the same time. And
Mm,
there's just a lot of people like it because you save more time, because it's going at the
yeah.
same time, it's simultaneous, and that's just and I'm like, well, I don't know, because one of my colleagues asked, and I go, I don't know. When I get on, I'll ask them, so we have an
Mhm. No, no, no. Yeah. I'm glad we have you on the call.
idea.
Um, mhm.
Sandra, does it help for you to see our slides ahead of time, or you're fine just like on the fly, like doing it right then and there?
It depends, how many slides do you guys have?
36.
26 slides.
But some
Yeah.
are title slides, and
Yeah, right.
some are like we're asking questions to the audience.
Mhm.
Um, So that'd be cool. Like our word cloud will have both English and Spanish words. So like we're asking, what does policy mean to you? What does advocacy mean to you? Like write one word. Um, so those are some interactive kinds of questions.
Mhm.
But hmm.
Well, if you have the slides like right there, it'd be nice.
Yeah.
Oh, Joe says he might not have the slides, or sorry, the access to the link. I'm gonna send it to.
Oh, darn. Okay.
If you don't, that's fine. Just because I don't, sometimes when you send stuff and there's links involved and Zoom involved, oh, things happen.
Okay. Sandra, what's your email?
Sandra Padilla, actually it's right there, Sandra Padilla 10 at msn.com.
At msn.com. Sandra Padilla 10 at msn.com.
It's the longest one. It's such an old email.
Yeah, no worries. Okay, these are the slides. I'm sending you the slides. It's a PDF and it has notes. I mean, some have talking points and some don't, but some are, yeah, so you let us know. We can always simplify things if it makes it easier for translation. Because we are calling out a few examples of policies that impact community health workers, things of that nature.
This will be a good reminder to pace ourselves and
That's what I was
not talk too
saying.
fast.
Yeah, I was saying that before you got on, Andrew, because I've been to in-person conferences before where there was a live interpreter, and yeah, everyone made sure they had to slow down as they were sharing their talking points.
And if we have, like, for example, let's say we have a conference in person and we have the equipment, we set up everyone that needs the interpreting, and then
Yeah,
you just go at any pace. It's so much fun, and then we just go along with you.
yeah,
The way most people like to have it. But to each their own, and everybody likes their own style, and everybody feels more comfortable, with either consecutive or simul. It depends on the agency, and it depends, I think, on what you want also.
yeah, and what the technology allows us to do,
Yep.
right? So,
Yep.
Sandra, can you check your email if you received it?
Yes, I have. Let me see.
Also, Rhodora and Sandra, just so you know, I think there's some attendees already on the call. So yeah,
Oh,
I
okay,
mean, yeah.
cool. Hey, welcome everyone. Love it. People are excited to join.
For the Nashua IT support, I have a question. So one of our co-panelists didn't get a email with a calendar invite. Can they use the link that was provided to either me or Rhodora?
Hey, so I actually just added her as a panelist. For some reason, she wasn't listed on the Excel sheet, so I couldn't add her beforehand. But I just sent out an email. So can you tell her to check that by chance? She should
It's a
receive one from Zoom.
Yeah, it's Joe
Joe.
Calderon.
Oh, you said Joe?
Yeah.
There's no Penny.
No, Joe
No.
Calderon.
Okay, I got you. I'll check up on that. Do you guys know his email by chance?
Yeah, I can type it in.
All right, perfect. Thank you so much.
Mhm.
Whoops, that's the wrong way. Darn it.
Not sure if you can see like what I just sent, but yeah.
Looking at the slides, it's really good.
Great.
All right, I just sent it out. He should receive a link from Zoom. For some reason, I believe they had the wrong third person with my group. I apologize for that.
Dun, dun, dun. So you just let me know when we're ready and when we're starting.
Okay, yeah, this is session 15A. Andrew, maybe do you want to have the title slide up just so people who are popping in the room know what session it is? Thanks.
Yes.
This is about, we're talking about policy today. So thanks for joining, everyone. 12 so far. Yeah, we're going to start, it's scheduled to start at 11:50. So we do have 8 more minutes. So
Yeah.
thanks everyone for waiting.
Oh, there's the screen sharing. Cool.
Okay, we've got Joe. Hey, Joe.
All right. Also, Sandra, I found out the interpreter icon for you, so I believe it'll it may put you in a different room. I'm gonna hit it and see what happens.
Okay, let's see what happens. Let's see, I have right now all the slides. That's what I have on my screen. Let's see.
Can you all see the slides and only
Yes.
that?
Yes,
Okay,
perfect.
great. Oh, well. Can you all still see the slides?
Yes.
Super.
Sorry, you guys. Laughing at my own trauma joke. I laugh quite often. Laugh at my own jokes.
Yeah, this is music we tend to play it when we're waiting for webinars to start.
Everyone breathe. We're gonna be outstanding. Not because of us, but because of the message we bring.
Also, guys, so Atani would like to know if they are able to get a copy of the slides. Is that possible?
Yeah.
All right, sounds good. Let them know.
Yeah, I'm trying to think what would be the best way to send that.
Is there a link by chance? that's closed off, like a, not an open edit link.
Yeah. Yeah, I can drop a link to the slides, view only.
Perfect, okay, thank you.
We encourage input from everyone, but through the comments, not through editing the slides. Anyone with the link? Cool.
Gosh, maybe we can do a PDF also. PDF. We'll be starting any minute now. So it's 11:50. Andrew, so shall we go ahead and get started?
Sorry, I couldn't find my Zoom window. What was that, Rhodora?
It's 11:50, so I think we can go ahead and get started.
Super, yeah. Let's get started. Hi everyone. Hope you all having a great day. Good morning to those of you still in the West Coast, and good afternoon to those in the East Coast and all in between. My name's Andrew Lindbloom, and I'm excited to be here with Rhodora and Joe and Sandra to present to you on reimagining healthcare, bold policy advocacy for community health worker empowerment.
We can't hear you, Sandra.
Yeah, Sandra, we can't hear you at the moment.
I wonder if her interpretation is it going directly to folks who need it? I don't know. For folks who need Spanish interpretation. Can you hear Sandra? Oh gosh, it needs to be said in Spanish.
Yeah, so when they hit Spanish, they'll hear Sandra.
Oh,
It'll
okay.
select at below, I believe.
Okay, so we don't need to pause in between.
Yeah, you could just allow a small pause just to be safe, but it don't have to be like extremely elongated or anything.
Okay, thank you.
Super. All right. I see that some of you have already done this in the chat, but as a big welcome to all of you, please introduce yourselves in the chat, include your name, your role, and organization. We're excited to have you all on today's call. So we're going to begin by setting, the tone and theme for this presentation. And we start with a bold statement. This is a Glenn E. Martin quote that says, "People closest to the problem are closest to the solution, but furthest from power and resources." We're hoping that both through the information that we share today and some of the very tangible tools that we share and experiences, that you feel a little bit closer to having that power and the resources to make the change both in your communities, your states, and at a national level. I already introduced a little bit of our co-presenters today. My name's Andrew, but there's no better person to introduce themselves than the individual. So I'll go ahead and start myself, and then I'll hand it off to Joe and Rhodora to introduce themselves. So my name is Andrew Lindbloom, MPH and CHW, but also a health policy lead here at PearSuite. PearSuite is a care navigation platform that allows organizations to both bill and make their workflows more efficient. So excited to be sharing the stage here today with the rest of the team. I'll hand it off to Rhodora.
Hi, everyone. My name is Rhodora Ursua. I'm a principal consultant at Community Health Synergy. We're a small consulting firm that focuses on advancing health equity through community-centered capacity building. And I've been doing work around the community health worker workforce for, about 20 years now. The CHWs are near and dear to my heart. I'm very happy to be here to share and also learn from folks in the session today. And I'll pass it on to my colleague, Joe.
There's almost nowhere else in the world I'd rather be than in a room full of community health workers and community health worker advocates as we strive to continue, our battle towards getting what we need through policy. I'm Joseph Calderon, first and foremost a community health worker, a practitioner, and managing recruiting and training for Urban Alchemy, which is an organization that looks to changing communities through love and respect and urban spaces. Thank you. Pleasure to be here. Looking forward to going over this and being really interactive as we strive to get the policies we need around community health work and serving the communities that we love.
Super. So we have a superstar team, mainly talking about Rhodora and Joe. And yeah, we're excited to talk about policy. So I'll start off by sharing a little bit of our objectives for this presentation. We want each and one of you, whether you're a CHW or a CHW ally, to understand policy's impacts on CHWs, the policymaking process generally, and how to get involved. The bullet points are just an overview of the different sections in a presentation. We'll be starting off with the policymaking process, then going into understanding the role of policy in the CHW movement. We'll discuss advocacy in action and what that looks like, what comes after advocacy, and then we'll have some closing remarks and next steps. But to start us off, we'd like to engage everyone and have a word cloud activity. So if you can please scan that QR code on the screen, I'll then switch over to a new window where you'll be able to see all your responses come in. So let me do that switch right now. Can you all see the question in the QR code? Super. So yes, once you scan the QR code, or you can also follow the instructions at the top, you can see the responses coming in. And we'll take a second for these to come in and also to reflect on some of them. All right, so these are slowly coming in, but surely they're here.
And sorry, Andrew, just to answer Deborah had a question in the chat or about the slides seeming small.
Okay.
I'm gonna download the PDF and drop it in the chat, Deborah, if that's easier to open it up, if it's too small for you to see it on screen. Oh, you can see it now, great. Thanks.
Yeah, sorry about that.
No worries.
Keep it coming. You know, what you believe about policy really gives us an angle on what we need to do.
Alrighty. Well, we'll just read through some of them, but it seems like, there's some themes around change and structure. So, the bigger the word is, the more responses that we're getting that use that word. So we have change, we have unintended consequences, recourse paths, proficiency, legal ways to impact work, opportunities for advocacy. These are all great, and I'm glad we are all, starting to think through what does policy mean to you, and mainly to the work that you do, on your everyday. So thank you for sharing. We'll go ahead and return to our slides. Super. So our first section is the policymaking process, a guide for CHWs. So, to start off on, this conversation on policy, it's important to have some certain understandings of the policymaking process. So there's no better way to do that than to begin with small versus big P policy. So you might hear these terms being thrown around, whether it be at a, CHW association meeting, or maybe, around your own day-to-day work. But to start off, big P policy usually refers to major legislative actions like bills that have a broad impact. And I know that's very vague still. So a clear example of a big P policy is the ACA, or the Affordable Care Act, which is federal legislation that reformed healthcare coverage and insurance. And in many states is responsible for, CHW reimbursement and paying for those services. We'll talk more on that later. And then small P policy, this refers to administrative rules and guidelines that affect specific areas. An example of this would be a county school board institutes an incentive policy for vendors to supply nutritious and affordable food for school lunch programs. So one way to think about it, big P policy, these are these major legislative actions or bills, mainly the rules of the land. And then the small P policies are how do we get to the intended consequence of those rules? How do they actually make them happen? Oh, and Sandra, apologies if I'm going too fast for you. So, now that we covered small and big P policy, we have types of policies. We'll start off with policies over to the left and navigate our way to the right. So this seems, like a lot of information on the slides, but this is really just setting you up to have better understanding on the other slides that we'll have. Starting off with bills, which these are the big Ps. These are formal proposals for new laws or changes to existing laws.
Screen sharing, language interpretation, click here. Thank you for coming. Speaker, please check your connection.
Sandra, I think we can all hear you right now, but yeah. So
yeah, look, it seems like it put you out and put you back in. Let me add you back to interpretation.
Thank you.
My speaker is not working. Hear me? Oh my gosh. Okay, more. I'm having issues with audio. Let me see.
No worries.
Interpretation of understanding the role.
What we can do is I can give you, a long enough pause for you to translate to all the whole group. So, going over bills again, big P, these are formal proposals for new laws or changes to existing laws. An example of this is the Community Health Worker Access Act, which is S3892, which would improve access to care for Medicare and Medicaid enrollees by boosting reimbursement for community health worker services and integrating them into Medicaid. So this bill hasn't been passed yet, but it's on the pipeline. It's an example of this kind of large bill that would have, would make changes to existing laws regarding CHWs and the reimbursement for them through Medicaid and Medicare. Then we have administrative rules, small p's. These are regulations set by government agencies. So an example of this, in California, there's administrative rules around documentation. So what does the CHW need to document in order to get reimbursed for their services? So there's things like documenting patient interactions, including challenges, assistance, and referrals, and ensuring that the documentation is accessible to supervisors, and also, in California, for example, to the MCOs. Legislative rules. These are regulations set by government agencies. An example is the 2022 HB 525, which came from Kentucky, granting the Kentucky Department of Public Health the authority to establish a certification program for CHWs. Next, we have resolutions. These are non-binding statements of intent or awareness, like CHW awareness resolutions. An example of this is the 2023 CHWAW, which is CHW Awareness Week, when Congress recognized community health workers through this Awareness Week resolution. And lastly, we have these state plan amendments, or SPAs, which are changes to state Medicaid health plans or Medicaid plans that can affect CHWs. We've seen this throughout different states, and we'll cover this more extensively in later slides. But an example is the 2022 California SPA, where it allowed for CHWs to be covered under Medi-Cal, which is the Medicaid program in California. So next section is understanding the role of policy in the CHW movement. Now, there's two main buckets that we wanted to bring to your all's attention, and this is in regards to how policy impacts CHWs directly. We've kind of neatly organized them here in two sections. They're not all, exclusive, but for the sake of this presentation, we mainly wanted to focus on funding to sustain CHW workforce, so policies that might impact funding, and then policies that might impact guidance around CHW training and certification. An example of that is the Kentucky example, where the state made it, made it law that there was a certification needed to provide these CHW services and get reimbursed. So this is a 50-state scan of Medicaid payment for CHWs, promotoras, and promotoras. So CHW reimbursement, 24 states currently pay for CHW services through Medicaid. These service guidelines vary. So what services are covered, what populations can receive covered services, payment methods and rates and authorizations. These vary by state. And then services coverage remain pretty consistent. So they usually do cover care coordination, system navigation, health coaching, patient advocacy, clinical support, and community outreach. Lastly, payment standards vary as well. So by payment standards, we're talking about the rates that Medicaid, at least for this moment, is offering for CHW services. So there's no clear standard for payment rates across the country, but they vary from $9.70 to $35. Now, visuals are always helpful. So here we've included a map of the states that currently do pay for CHW services through Medicaid. And then this is also a very interesting map that includes CHW certification. So the status among state public health agencies. here we can see that states with red are states where there's a state-operated program. There's also privately operated programs in blue, programs under development. So California, for example, there's still, the guidelines are still under development. And then the pink or lilac color is the no certification is found amongst those states or needed. Now I'm going to turn it over to Rhodora, who's going to speak to a little bit about the policies that we're seeing in California regarding CHWs.
Great, thanks all. Also, just for some interaction, zooming into California, I would love to hear who in the room is from our lovely state of California. You can do a heart reaction on the emoji if you're a fellow Californian. But otherwise, we might have folks from outside. Hey, a couple hearts. Yay, Californians. So thanks for sharing. So I just want to hone in on 3 particular policies that impact CHWs in California. So you heard Andrew already describe Medicaid reimbursement. This happened in our state just a little over 2 years ago in July 2022. It was done as a state plan amendment where that authorized for CHW services to now be reimbursed as a Medi-Cal benefit. And so Andrew did mention earlier how state plan amendment is a type of policy. And in this case in California, there was also engagement of community stakeholders on how to design that state plan amendment. I remember there was an advisory committee, there was opportunities for comment on the language so that it could be driven by what the true needs of community health workers in our state are. And then secondly, there's California State Legislation Assembly Bill 184, and this really honed in on how CHW PR initiatives should focus on implementing 11 core competencies for community health workers training and their scope of work. So examples of those core competencies are things like communication skills, relationship building skills. Advocacy is actually one of those skills. Facilitation, knowledge basics that community health workers should be aware of. So it highlighted that, as well as the valuing of community health workers having lived experience in their role. And so we all know that that's the beauty of community health workers, is that they have that shared lived experience with the communities they are serving. So like having personal knowledge of specific health conditions or experiences. And many of you are probably already familiar with that. And then thirdly, for CHW certification and training, there was a statute in 2022 that authorized the Department of Healthcare Access and Information. We call it HCI here in California, and they were given the authority to develop and implement a certification process for community health workers in California. That is on pause right now, and it's because the state wanted to do more listening sessions in our state to hear voices of community health workers, community health worker managers, and allies on what certification should truly look like in our state, so that again, it's CHW centered, CHW driven, and it's done in a way that is meaningful. And we acknowledge there is still confusion about it, but the state did choose to take a pause on rolling the official certification guidelines out. And in the meanwhile, in our state, it's just noted that these 11 core competencies, as long as community health workers can demonstrate those core competencies based on what the supervisors agree on, that is sufficient. So currently, certification is not tied to actually billing in our state as of yet. So the next slide. Advocacy in action. So we have another poll question. It's different from our policy question. Now we want to ask, well, what is advocacy mean to you? And so if you still have the screen up of the previous poll question, or you can go onto that, scan that code again, the QR code. Would love to hear from our audience. 1 or 2 words. What does advocacy mean to you? I wonder if you have to show the QR code. Oh, yeah, perfect. Yeah, we want some audience participation. What does advocacy mean to you? Needs a strategy, voice the people's needs. I love how in the chat, Ali had put a link to how you can contact your own members of Congress to co-sponsor the Community Health Worker Access Act bill. Change, lived experience priorities. Great. Yeah, these all resonate. Yep, people power. Advocacy is more powerful with people power. It means we're being a voice for those who are most marginalized and underserved. It's about defining the problem and the solution, and listening and helping support someone with their voice and story. I love that. It's about educating our local elected officials on the needs of our communities. No mas equity now. I love that. And having a voice when your patient doesn't. Exactly. I mean, that's the beauty, another beautiful value of community health workers is you are a bridge, you are a voice for the community members who are often unheard. I love that. Thank you all for participating in that. We'll go to the next slide then. So just wanted to jump into how advocacy, a definition of advocacy. You all shared a lot of great examples of that meaning, but we know it's a process of supporting, defending, or arguing for a cause, a policy, or interests, especially on behalf of marginalized or underserved communities. And why it matters for community health workers, promotoras, and representatives. Well, we know CHW PRs are uniquely positioned to amplify the voices of those who are often unheard. You know your communities best, who you serve, since you work so closely with them and are an amazing spokesperson for the community's needs. We know advocacy builds power within communities. It's a great way to engage the patients and clients that you serve, the communities that you're a part of, to also share their own voice. And we know it impacts policies, and we're going to share a few examples of that, how advocacy impacts policies, in this case, to grow and sustain the community health worker workforce. And I mentioned earlier how there's these core competencies that are guidelines of what key skills community health workers, promotoras, and representatives should have, and advocacy skills is listed as a key core competency. So the next slide, and these are just photos as examples of a coalition that Joe will be describing in a few minutes, but the next slide goes into a framework, and this is a framework that was highlighted at Harvard as advocacy power tools. And again, many of you may already be familiar with these, but just to call it out, for instance, research and data collection. We know that our advocacy messaging is more powerful when we have evidence to show for it, to back up our story. So any data points about the needs of our communities, any data points about the impact of our programming and why, there should be funding that continues to support those types of programs. I'm going to throw out there another engaging question in the chat. I mean, feel free to type in what's an example of a data point that you like to share in your region or state when you're advocating on behalf of your communities. examples, for instance, here in California, that the coalition that that Joe will be describing are data points like only 10% of community health workers who answered this particular survey felt that their current salary covers their basic needs. Only 10%, which kind of relates to that point about the reimbursement rates for CHW services being looked at as too low at this moment. Another data point that community health workers and advocates have shared is that 70% of community health workers who responded to this particular survey said that they don't know how to grow and advance in their career as a community health worker or promotores or representative. So highlighting the need for more investment in trainings and career pathway and career advancement opportunities. So I'm sure, I don't know if anyone has shared in the chat, but yeah, feel free to. So someone noted how, stats around unhoused persons who are employed and the misconception about unhoused persons not interested in working. Oh, that's a great point. When many actually are part of the workforce and don't make enough wages to afford housing, should any housing exist in their area. So great point. The data that we share doesn't have to be a statistic. It could be very qualitative as well. And stories are important to share when we are doing, for instance, legislative visits with our representatives. Another point shared by Ali was a randomized controlled trial found that one community health worker program yielded a return of $2.47 for every dollar invested, saving Medicaid $4,200 per beneficiary each year. Great point, highlighting the return on investment of investing in the community health worker workforce, given those types of dollars that are saved. Love that. So, yes, research and data as an advocacy power tool. Coalition building, we know how important it is to engage multiple key players to form powerful coalitions to drive our advocacy efforts forward. Joe, again, was going to share a perfect example of that here in California. And then when it comes to fundraising and development, we know that's essential for coalition building and policy advocacy, whether that's advocating for fundraising or advocating for funding for the community health worker workforce, or even just securing funding to do these types of advocacy efforts. For instance, here in California, we're so fortunate to have foundations like the California Healthcare Foundation that funded this coalition, this policy coalition on community health workers here in California and funded those efforts. So in your state, there might be examples of that happening in your regions. And the next slide, 3 other power tools are grassroots and key contacts. Who are the right people to be engaging in your policy coalitions? Again, the actual community members themselves whom these issues impact directly are the perfect people to be a part of these efforts. I know in advocacy efforts that I participated in when I was back in New York working with the community health worker workforce over there. We did a lot to have our community health workers also engage their clients to attend legislative visits, do public testimony, sign on letters, since their voices are really crucial in this space. And in the end, our policymakers represent them as constituents and want to hear from them directly as well. And then we know media advocacy is a great tool. Like we've all seen social media posts on Instagram, LinkedIn, all the Facebook, all the various ways we can get our message out there. And you'll see a few examples in a few slides so that we can raise awareness of our issues, garner support perhaps put out a call to action. Hey, we'd love you all to sign on, to this particular letter to the governor. And then decision maker advocacy. This is, speaking directly to our policymakers, whether it's through, working with policy advocacy coalitions or groups to organize those types of meetings, calling our legislators, like I said, signing on to letters. Other examples are having forums where you invite the legislators to your organization, hosting a forum and bringing all of your key leaders, community health workers to the room to speak on the challenges and needs that your communities are facing. And that's very powerful because you have that direct tie to try to influence that policymaker or decision maker's opinions on the issue at hand. So in general, those are 6 power tools. I imagine many of you already utilize these or have seen it in action. But we'll go to the next slide and I'm going to hand it over to Joe, who's going to have amazing stories to share with you on how all of this plays out in real life.
Let policy heal what policy has harmed. And when I think about some of the policies that have for decades have communities of color been systematically disadvantaged by policies rooted in racism and inequity. Some of them are the war on drugs, redlining, mandatory minimum sentences, the 3 strikes law, affordable housing and urban development policies, and immigration policies. When we think about the United States of America, let us not be deceived. The 2 biggest mental health facilities are Rikers Island and LA County Jail. What I ask of the community health workers in a room today is, we're willing to go to war for our patients, for our clients, for our communities. It's time for us to go to war for ourselves. Who's at the table? Who's developing these policies? That's a question that I want you to leave this room thinking about. And if you're not at the table, you're on the menu. And it's time to crawl up off that menu and get what our communities need. And what our communities need is community health workers that are properly supported with a living wage off the top. Thank you. Next slide, please. When we think about the 3 B's of policy, I always think about bridges, barriers, or biases. And I beg our policymakers, if we have policymakers in the room today, when you're making policy, I beg you to really think about intent versus impact. Who's at the table? Who's defining the problem? Who's defining the solution? And are we building bridges? Are we building bridges? And if your answer is for a room full of table of system people, then I have to argue that intent versus impact, where you might have the intent to do so well for our communities, but haven't sat down with our communities to even define the problems, haven't sat down with our communities to even define the solutions. I'm sorry, we have a multitude of policies that have not helped, but have definitely hurt the communities we serve. Slide, please. So when you share, can anyone share examples about the 3 B's you encountered in your experience? What are some policies, whether local or national, that you've identified that either have hurt or harmed our communities? The 3 bridges. Have they been bridges? Have they been barriers? Or have they been biases? Let's throw a couple out there. I threw about several. If you want to use those again, please do. We know, like, such as the war on drugs, destroyed communities socially and economically and caused a lot of generational trauma. So when the question is, who should be at the table? What part do community health workers play? Then I think the answer is off the top that we need to be involved. We need to be bringing our people's problems to the front and making sure that when the solutions and the problems are being defined, that the community is at the table. The 3 B's. Any examples? Is this a word pull too?
Yes, pulling it up in a second.
Okay, thank you. You know, I think it's easy for me to say and believe in whole heart that more people have died with the pen than with the sword. Policies are important. Let's make sure we have the right people at the table. In a minute, we'll be discussing, after we do this word poll, we'll be discussing a little bit about the CHPR Policy Coalition and the work and some of the work that we've been accomplished in California, you know, led by CHCF funding and CPEN as the tip of the arrow. Andrea Mackey for sure has been a force to reckon with, and a force that has brought together a multitude of other organizations that are doing the work. You know, and when we think about that, as we wait for this, you know, let me give those organizations their proper respect when we think about the CHCPR, and then we can discuss a little bit about, okay, here we got it. Let's go back to 3Bs. I'll slow down. We only have 70 minutes, you guys. So what in your communities, local or state or national, you know, when you think about the 3Bs, what have you encountered? Have you encountered bridges? Have you encountered barriers? Have you encountered biases? And you can put up those, please. So we see barriers, whitewashing, and even well-intentioned policies. This happens when a community is at the table. Hello. Threat of defunding, Ryan, white program, and overall HIV. Always, right? Our programs always to be on the cutting board. Barriers prevent us from providing services to patients that need more than 6 rides a year for important medical attention. What sense does that make? Do we got one more out there? Anybody else thinking about a bridge? Is there a bridge in your area? Are you doing policy work? Who's in the room? Barriers, religious exemptions, provider can refuse provider services, medication, and patients based on their religious beliefs. Adam, thank you for saying, yeah, the people's agenda. I love it. I love it myself. Please, you know, go ahead and do some research. Look at what's going on in California. If your state is thinking about, you know, actually certification, look at some of the steps we made. We need to watch the other states that have done certification. Where did they drop the ball at, and where did they do well at? Next slide, please. So here's the organizations that were involved. You know, I guess the Latino Coalition for a Healthy California, the Children's Partnership, the California Consortium for Urban Indian Health, Roots Community Health Center, Vision y Compromiso, and Transitions Clinic. And, you know, I have to say that being at this table has been a pleasure, because when I think about the needs of what my community needs, and when I was at this table, I represent several communities. I represent returning community members. I represent half-breeds. I represent, you know, community health workers, promotoras, and community representatives. I went to this open-minded, and I went into this hard and strong. You know, in California, the only one thing that I think we need to get right is some unity. And I think that's perfect to talk about when we're talking about NACHWA and unity. We need no mas, equity now. We need the promotoras in California to come together and be one voice, so that Governor Newsom could give us what we need to actually see to the people's needs. This has really been good, because I've been able to advocate for community health workers, for histories of incarceration. I've been able to advocate, you know, for more funding. I've been able to advocate and be a voice for those that either don't have a voice or those that don't have access to the tables. And I will continue to be that voice of the people. And I would always do it humbly with no ego. I want to represent the people's cause, the people's needs, and policy should be supporting that. Let policy heal what policy has hurt. Slide, please. Art. The CHPR Policy Coalition also developed California's first CHPR policy agenda, which consists of 15 priority recommendations, each linked to one of those 4 policy priority areas: workforce development, economic equity, effective integration into care teams, and the equitable access for Medicare enrollees. This policy agenda was led by 152 CHPR members. We had several meetings and peer CHRs. We were asking people that weren't CHWs PR to leave the room. It was great. And we had 152 that spoke, and their voice was heard. And let your voice be heard wherever you're at, what state you're in. Make sure you're in the correct rooms. I hate to, sound, like this is a reason why people are dying, but people are dying. I don't want to be melodramatic, but when people are dying, we need to speak about it. You can access these 3 awesome resources. Ro will be putting that, Rhodora will be putting that in the chat. We'll put both English and Spanish so you guys can at least look at the policy agenda and what California has accomplished thus far. There's nobody on earth I love more than I love community health workers. Slide, please. So the coalition organized the state's inaugural information hearing in Sacramento, which showcased our state assembly health committee and the dynamic CHPR workforce and community power to legislators to the state agencies. We went to Sacramento. We made sure that they heard our voice. I think when we're dealing with allies, when we're dealing with anyone, we don't need the white savior. We need the white advocate. We need people to be invested in this movement, because I do believe that the community health worker movement with proper investment will truly be able to heal where policy has hurt. We'll be able to bring medicine. And healers need healing too. So, we had to advocate for a bunch of things. Here's an image of Andrea Mackey, CPEN's associate organizing director, whom we have to thank very much for sharing a lot of these materials that CPEN has done a lot of hours, research, and work on. Thank you, Andrea. Thank you, CPEN. She was joined by other leaders and allies and promotores representing and providing public testimony. My experience with public testimony, has been, I have to say, for the most part, has been really successful. I have to say that if we could get to those tables, and at those tables, if they're listening to our voice, we got to continue. And we'll share some of the wins and some of the struggles also with what we're going through. Slide, please. The power of communication and campaigns to raise awareness, muster support for your cause, and promoting a call to action is priceless. Here's examples of some social media posts by coalition members. Earlier, it was said that some of the numbers that Rhodora shared about how many CHWs feel like they're making enough money, about how many CHWs know about policy, about how many CHWs are making it to the table to actually define the problem and be a part of defining the solution. How many? Is it happening in your state? And if it's not, how do we get there? Well, I'm hoping that some of the resources we shared today will get you motivated enough to make sure that the correct people are at the table, and that we're filtering our allies to make sure that we have allies as we move. Here is a perfect example about how we can use social media to reach a lot of the community health workers and promotoras that are out there, that are frustrated, that are working 2 jobs just to get the bills paid. And one of them is a community health worker position because they love this work. Let's make sure that any state that's moving towards certification is also advocating for the CHPRs to actually make a living wage. It would be lovely as a community health worker if you could have 1 job and pay all your bills, and maybe having healers need healing too, maybe even have a 2-week paid vacation. Hello? Slide, please. In this case, the CHPR coalition in California, we had a call to action, which was supporting to assign on to a letter for the governor to advocate for higher reimbursement rates and just equitable levels so that CHWs can be properly reimbursed and given the high value they bring to improving health outcomes for the most marginalized communities. Having done this work for several decades and being a community health worker, before I was a community health worker, I realized how important lived experience is. I realized how we can address safe mistrust of systems. I realize the love and passion, blood, sweat, and tears that community health workers put into this work. I've met many promotoras and community health workers that are volunteering to do this work and having a job. That's a shame on the system. And we always have to remember, where system thinkers might have the intent to help us, the impact isn't always what it's meant to be. And that's because the right players are not at the table. So once again, I might say that several times. Who's at the table in your state? What moves are you making? And how can we improve and come together, because we're stronger together? Slide, please. The coalition's extensive interactions with key legislators and their staff culminated in a notable budget victory to increase Medi-Cal rates for CHPRs. Now, this is something that needs to still be voted on, right? I believe it's coming up in November. So if you're from California, stand up. If you're from California, stand up. If you're from California, stand up. In November, we'll be looking at CHW rates. You should be talking to all your friends, all your associates, anyone that will listen. And hello, use social media. Let's get the correct votes so that our communities can get these healers that have been around since communities have been around. Community health workers have been around since communities have been formatted. Let's go ahead and do the right thing now and make sure that we get the correct funding, to make sure that we get the correct certification, the correct training, so that no one's going in the field and representing a community health worker, promotora, or anyone else without the skill sets that they need to make sure that the healers need healing, but so do our communities. So let's take our time in the certification process and have a clear understanding about what training we do need. HCI listening sessions were great, but we're at a freeze right now in California. CHWs chimed in on what training needs are, what the values of certification could be, uplifted the importance of medicalizing the CHW role and preventing the drift from true essence of who the CHWs are, and how HCI's funding should support CHW training and the CHW's needs. For instance, one CHW leader at Oakland highlighted how one of HCI's funding mechanisms to fund CHWs to actually attend a service of trainings should continue to be scaled. How are we going to invest that HCI money? How can we make this workforce stronger? Training, training, training. Slide, please.
Great. Thank you so much, Joe. Super powerful. So I'll take these next few where I want to share what comes next after advocacy. And at the end of the day, advocacy continues on even after the policies pass, correct? And so next slide, I want to just share examples of ways that we continue to support the key partners, the organizations who are out there in the field actually implementing the policy. And so one example is continued research and evaluation. So in our sense, for instance, at Community Health Synergy, we were tasked with collecting data from managed care plans, community organizations, health departments on, what are they still being challenged by in actually utilizing the community health worker services benefit. And so we know there is a low uptake currently on that. And a lot of it is because folks are still confused or not as aware of what, how to apply, or the processes themselves might seem very burdensome. And so we helped uplift a lot of these concerns that that community organizations are experiencing to the state, so that the state could implement different things such as, how do we improve training resources or streamline processes better? How do we uplift successful partnerships already happening in the field where a managed care plan and a community organization have an excellent partnership and are utilizing this benefit in a successful way? So research evaluation, educating and partnering with the state agencies to, like I said, continue uplifting the community organizations' voices, the CHWs' voices, so that more organizations can tap into this benefit and ultimately have resources to reimburse this workforce. Again, we know the rate is too low currently, but hey, that's a win that hopefully this rate will increase come January. And then, like I said, with training and technical assistance, we know that the CHW employers, could benefit from additional training and support to tap into the community health worker benefit. So examples are things like trainings on how to contract with a managed care plan, trainings on how to set up your billing infrastructure, or work with a hub that can do that for you. We've heard needs on how do I, tap into, or how do I partner with educational institutions that are training community health workers so that we can hire really qualified community health workers who might already be skilled up. How do we braid funding? Like I said, we know that the Medi-Cal reimbursement funding mechanism isn't enough to support a full-time living wage. So the reality is we know that organizations have to braid funding. So how do we utilize community health worker benefit reimbursement plus grants, plus perhaps funding via enhanced care management through CalAIM types of funding mechanisms. And then as far as uplifting models of successful implementation, we have been partnering with the state, again, funded by California Healthcare Foundation, to do webinars. We're calling them Bright Spot webinars to highlight successful partnerships. So we actually have one coming up on August 27th, and I'm happy to share information if folks are interested. But, we heard, again, through our research that organizations out there want to know that, well, who is utilizing the benefit and how are they doing it in a way that's successful? How could we learn from them and replicate their successes? And it is a journey. We, I do want to give the state some grace. We know it's not always easy and it's not going to be perfect the first time when new policies roll out, but that's the beauty of partnering with them and with philanthropy and with key leaders across the state to make this successful, because ultimately, it's in support of our wonderful community health worker Rhodora's representatives workforce, so that they can continue doing the great work they do to improve health outcomes for our communities. And then we know that advocacy continues on, right? It's a cycle, and we want to continue showing the impact of the workforce and CHW programming, ultimately the impact of this funding mechanism, the impact of training and certification when it rolls out, so that we can continue having that supported in the long run. And so the next slide is just a quote, another hopefully inspirational quote for you all. Alex Fajardo, the executive director of El Sol Neighborhood Education Center, very well-respected, very tremendous leader in the CHW field, and a tremendous advocate for the workforce. They do amazing trainings for not just community health workers, but CHW organizations. And his quote is, the CHW PR model was founded, developed, and has existed for many years to bring social justice. The system belongs to the community and was created to change systems, not to please systems. So whoever wants to run this model needs to understand this. Whoever is selected to do this work has to have that calling, right? I'm going to influence and change systems. That mentality to want to change the system and challenge the paradigm is very valuable. So thank you, Alex. And I believe that ends our presentation for today. So we did want to move into, well, here's a bunch of links to resources. Thank you to our participants who've been so great at, actually, you were doing my job for me. I was going to drop all those same links. So thank you, Adam and Ali and others who have been dropping resources, but the advocacy platform, the toolkit, and then, yeah, the policy agendas, that's already all in the chat. So the next, I think, is just we want to open the floor for any questions the audience has for our speakers, myself and my co-panelists. And I'm not sure if you all just want to raise your hand and we can call on you and we can unmute you so that you could ask your question. You're also welcome to put a question in the chat if you like.
Yes, I believe if anyone has a question they want to speak out about, they can raise their hands and we can have our facilitator unmute them.
Questions? What is, yeah, go ahead.
I was gonna say, good question on the chat about what MCO means. So MCO is Managed Care Organization. Yeah, there we go. Thank you, Adam.
Hey, Daisy had her hand up for a while, so I'm going to allow her to speak.
Okay.
Go ahead, Daisy.
Sorry, I had my hand up. I didn't really have a question, but I did want to say thank you for the presentation. I loved how everyone spoke. But that's it. Thank you.
Great. Thank you, Daisy. Thanks for being here. Any other questions? If not, we'll give like another minute or so, but if there aren't any other questions,
Ali
we
has a
have
question.
questions for you. Oh, great.
Hi, thank you so much for this presentation. I was curious what supports, like, I know, I think a little bit about all of your organizations, but I was curious more like, do you all three of you particularly work in California, or are you doing more support in different places? And then how do you see the differences in what CHW networks are experiencing when it comes to policy advocacy, particularly?
Yeah, yeah, maybe we can each go around and share, if it's relevant. Yeah, so I here on behalf of Pearsuite, and Pearsuite does work in other states other than California. Obviously California there's a lot going on and there's a lot of excitement, but there's also, it's a good reminder that there's great work being done in other states too. For example, in the state of Michigan, that's a state where we are kind of growing our impact and presence, and Michigan's especially exciting because they, referencing the comment on the chat around relying on MCOs, Michigan allows for direct fee-for-service reimbursement from the state's Medicaid plan. So, that's something that we've seen that's different from California that has opted for, the MCO pathway. There's also states like Colorado who will be allowing for CHW reimbursement, who are kind of trying to decide what to do, and they're actually having what is essentially kind of townhouse meetings where they're allowing CHWs and other stakeholders to put their input, like, should we rely on MCO, should we not, what's going on in California and how should that influence what we do in Colorado. And then there's also states like Ohio who have adopted a hub model, and that's really interesting because a lot of the work relies on those hubs. These are really admin hubs. So yeah, with us working in different states, we've been able to see both the pros and cons of different pathways that states have taken. And one thing's the policy, but as Rhodora can probably attest to, the other thing is how do we operationalize that and make it happen easy for CHWs and CBOs to build sustainable revenue models.
Thanks, Andrew. For us at Community Health Synergy, we primarily have been working in California and are trying to tap into, supporting various managed care plans across California and community-based organizations. California has, for instance, 24 managed care plans, and we're trying to support them in, better partnering with community organizations to implement the community health worker benefit. And so once we've done that, we actually do want to tap into other states who might be experiencing similar challenges. Our work in other states has touched community health workers on different fronts. It's more at a local level. For instance, in Alaska, we're supporting an organization there that's implementing a community health worker model to address gender-based violence in the Pacific Islander communities. So it's been more local levels, but yeah, it is our desire to expand beyond California to support other states. Joe, anything to add?
While I'm presently working for a national organization of practitioners who I'd like to, I honestly see as community health workers, I haven't been doing no policy work out of California recently, but obviously in my last job, I was at least tracking nationally the clinics and communities that we did the trainings with, and as we expanded with TCN. Other than that, I've just been following what's going on in California and really hoping that California can get it right and learn from the other states that certified by seeing what mistakes they made or what they feel they missed. So in the process of us continuing to strive to to get our certification, just for California to be able to do it right, so that the states that will follow will have a framework to follow.
Great. Thanks, Joe. Any other questions? I know we have 8 minutes. I can't see if there's any other hands raised. Does anyone else see any other hands raised?
Nope.
Okay. And if not, and I know we have 7 minutes, we'd love to hear from you. And again, we can unmute you. We'd love to hear if anyone wants to share from their state, any examples of policy advocacy efforts, who's at the table, why or why not, what ways have CHWs in your state engaged in advocacy? Is there a win that you want to share? Things of that nature. You can answer any of these questions. And I know Melissa already in the chat said in Michigan, the Community Health Worker Association there works so hard to get Michigan CHWs like me to become Medicaid billable. So awesome. That was a great win. Any other wins to share or just examples of advocacy efforts in your parts of the nation? You can raise your hand. You can write it in the chat. Adam? Can we unmute Adam?
Hi, can you hear me?
Yes.
Oh, thank you very much, Rhodora, and everyone who presented. I just would have a question, and probably we'll get the information later, but once Medicaid billing becomes, put into law, and then it has to be funded, and then the question is, there's the implementation, but over time, the appropriations could change. The state might not actually fulfill the ability to provide services through Medicaid. And there's just so many imponderables. It's not a slam dunk. There's no one way to do it. And the examples that have been already given show how it's being approached from so many different avenues, and it's going to, so the idea that the CHW should be funded. This is something that I've been wrestling with ever since I learned about CHWs, which was only a few years ago. You can train all the CHWs you want, but who's going to pay them? Who's going to employ them? How are they going to be paid? It's just, before we can celebrate too many wins, I mean, we have to realize that this is, the birth of a profession, or whatever you want to call it. It's hard. It's hard work, and it may not go like it's going to go.
Yeah, I completely hear you. Thank you for calling those points out. We do hear that often, and the other day, the Center for Healthcare Strategies actually did a webinar about braided funding, because they said, and the reality is, right, we can't rely on one funding mechanism, especially like you said, Adam. There's uncertainties of the future. And so when they talk about braided funding, it's about like, well, how do we utilize the resources at hand to support this workforce? And we hear the challenge about, Joe had mentioned it earlier, that, we've heard from CHWs the concern of when it becomes billable via Medicaid, are you over medicalizing the profession, right? We know that reimbursement doesn't cover everything that the CHWs do. We know it takes time for a lot of outreach calls and unanswered calls, and that time technically isn't reimbursed. And we know there's all these other support efforts that CHWs provide their patients and clients. But at the end of the day, yes, that's why we're doing this session around continued advocacy and the power of that. And in the meantime, what are ways that through coalition building, through developing infrastructure, through braided funding, we know philanthropy has come in a lot to support and help fill the gaps and provide bridge funding until these more sustainable reimbursement mechanisms are truly in fruition. But that's just some insight I had. Andrew, Joe, anything you had to share to Adam's point?
No, I thought that was covered it, most of it.
Yeah. Any other questions? I see your hand up still, Adam, or is it just because you haven't put it down yet? Okay. Any other comments or responses to any of these questions? Otherwise, Andrew or Joe, you're going to close this out?
Yeah, quickly, I always like to think about that we're one people, we're one movement, and there's only one love. We've been separated by racism. We've been, greed has damaged our communities. The power of the pen has killed. But being an optimist in a room full of community health workers and community health worker allies, I know that we can bring this home. I know that we can get the voices together and push through and get the votes we need to make the politicians listen. If we're not at the table, we're on the menu. If we could come off mic, I would have you do a unity chant. When I say unity, you say power. When I say unity, you say people. We are the power. Let's never let them remove that from our hands or our minds. And let's stand together, whether it's in California, New York, Texas, Minnesota. We're stronger together. So let us come together. Community health worker is the umbrella that's beautiful, and it encompasses many other titles, promotoras, community, all of them, practitioners, et cetera. And I would love to see more of us coming together to talk about what we need, what we want, and how do we get there. Thank you guys for listening to us today. I want to give a shout out to, both everybody here, Nachwa for having us, Ro and Andrew for being awesome. I believe this is a topic that, while it's not the most interesting topic, it's not the most fun topic to talk about. Without policy, what foundation do we have to sustain the work that we do, to bring the needs of the community to the policymaker and the policies that give us the people's money? Hello, our tax dollar, hello, to bring back and heal our communities like they should be. Let us hope that we continue to strive towards a government that loves its people more than it loves the money. Thank you all. Thank you all.
Thank you, everyone.
Thanks, everyone. Take care. Thank you, Sandra, for interpreting.
Yes, thank you, Sandra.
Yeah, thank you all. This was great.
Hard work.
Yeah, and thank you, Joe and Rhodora.
Thank you,
it was
Andrew and
lovely.
Joe.
Lovely
Thank
working.
you and Pear Sweet for everything you're doing to support
I
community
know.
health workers, not only in California, but several states. Thank you, Pear Sweet.
Of course.
Thank you, Andrew. Thank you, Kobe. Thank you, Ro.
Yeah,
Alrighty.
likewise. Let's all partner some more.
Yes.
We will do this
All
again
right.
somewhere else.
Yeah, we will. In person.
Take care, you guys.
Okay,
Bye.
take care. Have a good day, everyone. Bye.
Stay in touch.
Will do.